Hello and welcome, everyone. Thank you for joining us here today for Words Matter Language and Stigma Reduction webinar. Whether it's morning, afternoon, or evening, or wherever you are, your presence here matters, and we're grateful to have you here. My name is Hannah Lowry, and I'm honored to moderate today's event. This series is proudly hosted by the Colombo Plan, the International Society for Substance Use Professionals, or ISSUP, Faces and Voices of Recovery, and the Global Recovery Network. These organizations are working together to strengthen recovery systems worldwide. While we wait for a few more folks to join us, I will begin by saying a little bit about ISSUP, a membership organization for the global substance use workforce, with over 35,000 members worldwide. It is an international network that unites, connects, and shares knowledge across the substance use prevention, harm reduction, treatment, and recovery support workforce. ISSUP's global mission is to make the work of members as impactful, accessible, and effective as possible. They do this by making it easier to discover and share evidence-based knowledge, best practices, training, and networking opportunities. If you haven't already had the chance, please head over to ISSUP's website, which is issup.net, where you will find out more information on how to sign up for a free membership. The website also has a ton of resources and publications for you to enjoy, all free, and you can watch recordings of past webinars and see future event listings. We also will be posting those links in the chat for you to see a little bit more about our organization, Faces and Voices of Recovery, and ISSUP. I would also like to take the time to thank ISSUP staff for providing technical support for this webinar. This is actually part of a 6-part series taking place every other Tuesday, concluding on September 30th, which is International Recovery Day. Each phase of the series focuses on building knowledge and capacity across 3 areas: core foundations for recovery, returning to basics, and leadership development. Today's session continues our returning to basics phase. Today, we journey into the presentation Words Matter, Language and Stigma Reduction. It's my pleasure to introduce our presenter, Carolina Guerrero. A very warm welcome to you, and it's a great pleasure to have you here with us today. A little bit about Carolina's background. Carolina is a dedicated and experienced professional with a university degree in psychology and a master's degree in community mental health. She has over 15 years of professional experience in coordinating substance use disorder treatments and has developed and edited publications on mental health topics and led social inclusion and gender perspective strategies across various programs. Throughout her career, she has successfully spearheaded numerous initiatives aimed at improving community health outcomes and fostering collaborations among different sectors and countries. She has extensive experience working in the field with vulnerable populations and has conducted different research projects to improve access to information for decision makers. She has also completed various special courses in substance use disorder treatment, gender-sensitive approaches, and public health strategies, which have further enriched her expertise. She has served and continues to serve as a consultant for a variety of international organizations, such as the United Nations International Organization for Migration, UNODC, the Colombo Plan, and the Pan American Health Organization. In these roles, she has worked on issues related to substance use disorder, gender, human rights, and intersectional approaches for vulnerable populations, contributing to the development of programs that promote social justice and equality. Her role as a board member of several organizations focuses on empowering individuals from vulnerable communities, allowing her to apply innovative approaches to education and workforce development to ensure sustainable impact. She has an extensive track record of providing master training in international settings, overseeing initiatives to improve the quality of treatment centers, incorporating gender-sensitive strategies, delivering specialized workshops aimed at capacity building. Her work is driven by a commitment to social justice and a passion for creating opportunities for populations that have historically been left behind. Additionally, she coordinates the OAS-CICAD strategy on stigma, women, and substance use disorders for Latin America. Before we get started today, I would like to go over a few items so you know how to participate in today's event. Today's session is in English with interpretation available in Spanish. You can check the link in the chat to access the Spanish interpretation. The session will be recorded and you will receive the slides, video, and other resources via email after the session. You will have the opportunity to submit text questions to our presenters by typing questions into the question panes of the webinar interface on your screen. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Now, at this time, it is my great pleasure to hand this over to Carolina. Carolina, the floor is yours.
Well, Anna, thank you very, very much. That's a lot of a description that make me feel like I'm really glad to be here. Thank you very, very much for your presentation. I will now share my screen. I hope you can listen to me. Thanks everyone for being here. Let me check if I can do this correctly so you can see. Okay, I'm sure you can see correctly now. In any case, you just tell me. Okay, so welcome to the Faces and Voices of Recovery webinar, Words Matter, the Impact of Our Words, Language and Stigma Reduction. Thank you very much for joining us today. Thank you, and thank you very much, ISSUP, for supporting this webinar and for working together with us so that everything runs smoothly. Both of you have been there giving our support, so thank you very, very much. As Hannah says, I'm Carolina Orledo. I'm from Argentina, and I have been working with individuals, families, and communities across Latin America over the past 2 decades. My passion for this topic comes both from my clinical work and powerful life stories I have witnessed. These stories show how stigma can be as harmful as the challenges people face related to substance use, and how changing our words can transform recovery paths. Today, as we define stigma, summarize the types of stigma, describe examples of the impact of stigma, differentiate stigmatizing and non-stigmatizing language, apply strategies to end stigma, I will also share real-life examples from my own practice to bring these concepts to life. A World Health Organization study with 14 countries found that substance use disorder was among the most highly stigmatized of 18 conditions. Let's have a look together at this powerful definition. Stigma is a degrading and debasing attitude of the society that discredits a person or a group because of an attribute. Stigma destroys a person's dignity, marginalizes affected individuals, violates basic human rights, markedly diminishes the chances of a stigmatized person of achieving full potential, and seriously hampers the pursuit of happiness and contentment. This great definition is from 2015 from International Conference on Stigma from Howard University in Washington, D.C. As we revisit this definition, I would like to share with you the story of a woman I recently met in a consultation. Through her experience, we can see how stigma is not just a concept, but a reality that develops step by step. Let's start again. Stigma is a degrading and debasing attitude of society that discredits a person or a group because of an attribute. In the clinical case, a young woman who uses drugs during pregnancy is labeled by her community as a bad mother before any professional evaluates her situation or even offers support. That attribute, the substance use, overshadows all her other qualities as a person. Let's continue. Stigma destroys a person's dignity. In this example, after receiving humiliating comments at the hospital and noticing how staff avoid speaking directly to her, this woman begins to feel unworthy of care, internalizing that degrading perception. The definition says that stigma marginalizes affected individuals. And in my example, as a result of this woman stops attending prenatal checkups to avoid hostile treatments, becoming, in this sense, excluded from medical and social care systems. Stigma violates basic human rights. This woman is denied full information about treatment options and threatened with losing custody of her baby, violating her rights to health, information, and motherhood. Stigma markedly diminishes the chances of a stigmatized person of achieving full potential. In this clinical case, the lack of support and access to services leads her to interrupt treatments and prevents her from resuming her studies or securing stable employment, limiting her personal and professional growth. Finally, stigma seriously hampers the pursuit of happiness and contentment. In my clinical case, social isolation and internalized guilt distances her from support networks and activities that once brought her joy. This harmed her mental health and life plans. She was finally referred to our practice by a court order that mandated treatment. And I wanted to say that such moments highlight the importance of recognizing them as opportunities to foster change, to rewrite the trajectory of someone's life. This new story begins when we, as professionals, choose to approach her suffering with empathy instead of stigma. As we continue, let's look at how stigma takes different forms. Stigma is not a single experience. It is a multifaceted phenomenon that can show up in society, institutions, and even in the way a person speaks to themselves. Understanding these different types is essential to see how stigma can penetrate every layer of life. Let's define public stigma, which is highly harmful. It refers, as you can see, to the beliefs and perceptions that society at large holds about this issue. And it is shaped and amplified by the media, of course, and digital platforms which spread it through various resources and narratives. Then we have the perceived stigma, which is the belief that others have negative conditions and biases. But let's have a look at self-stigma, which, in my opinion, is the most painful dimension of stigma and really the hardest to address, as individuals are often unaware that they have internalized, in their own inner voice, the messages that are imposed on them from the outside. Over time, self-stigma becomes part of their identity and severely undermines their self-esteem. Phrases that we as therapists commonly listen, such as "I'm worthless," "I'm garbage," "I'm selfish," "I only think about myself," are self-definitions that most of the times have originated in social and family narratives, eventually becoming deeply ingrained within the individual. Then we have the concept, as you can see, of label avoidance, which is the way in which someone avoids or delays in seek treatment or help to avoid being assigned a stigmatizing label, as I have just told you about my patient. For example, a person can avoid therapy to prevent being seen as mentally ill, or skips substance use services to avoid the addict label, or refuses psychiatric care fearing it will harm his or her career. Then we have stigma by association, which is the avoidance of family members and others associated with persons who have mental health or substance use disorders. For example, it might happen a close friend of a person with a substance use disorder is excluded from social activities because the group perceives them as part of the same environment. Continuing, we can see institutional or structural stigma, which are the negative attitudes and behaviors incorporated into policies, practices, and cultures of organizations and social systems. Here I could give hundreds of examples, sadly. I will give you two now, and then we will talk a little bit more in the next slides. For example, health insurance policies that exclude coverage for mental health or substance use disorder treatments while covering other medical conditions. Employment policies that automatically disqualify applicants with any history of psychiatric hospitalization, regardless of their current ability to work. And finally, we have health practitioner stigma, which are the stigma, biases, and negative perceptions that impact access, quality, or type of care. For example, a nurse refuses to administer adequate pain relief to a person with a history of opioid use, fearing that they are drug-seeking. So, by stigmatizing people with mental illnesses or substance use disorders, communities lose the positive resources that those people have. And most importantly, stigma perpetuates fears about mental illness and addiction. As you can see, I'm drinking mate while I'm here talking with you, which is my national beverage. So I feel warm and close to you. So, what about stereotypes? This example I'm going to give is drawn from Amnesty International, which have a lot of publications on women and drug trafficking. It reflects not only the situation we are currently facing in Mexico, but also a broader reality, which is a global reality. The way women are disproportionately affected by criminalization, exploitation, and stigma in the context of drug trade. One of the most effective ways the war on drugs justifies violence, this is my point of view, is by stereotyping its enemies, the various players in the drug trade. In Mexico, marginalized women, often, of course, with little education or really very, very little economic opportunities, are recruited by drug cartels for high-risk, low-wage roles because they are seen as expendable. Authorities exploit this by targeting these women. They are, of course, easily arrested, falsely labeled as accomplices of organized crime, and frequently they are subjected to sexual abuse and coercion by security forces to inflate arrest statistics. This reflects a broader narrative that portrays them as disposable and morally suspect, reinforcing social prejudice and denying them justice, protection, and opportunities for rehabilitation. I chose this example because it powerfully illustrates how stigma, stereotypes, and structural violence intertwine. Of course, there are many possible cases we could analyze, but this one exposed several layers at once. How marginalized women are seen as disposable, how authorities exploit these stereotypes to justify abuse, and how stigma not only labels them, but also denies them justice and access to opportunities. In other words, I think it encapsulates how stigma operates simultaneously at individual, community, and institutional levels, making it a very telling case to reflect upon. And as we just saw in the case we discussed, the experience of these women is not isolated. According to the World Drug Report, the 2025 World Drug Report, which was just published, across the world many women are imprisoned for minor, non-violent drug offenses such as possession for personal use or small-scale transport. In fact, drug-related crimes are the leading cause of female incarceration in several countries. Women are also more likely than men to be held in pre-trial detention, which prolongs for a long time their imprisonment unnecessarily. What these findings show is that the stigma and discrimination against women are embedded in laws and institutions themselves, reinforcing the idea that they are guilty, that they are disposable, instead of recognizing the most important thing, which is the poverty behind that, the violence, the exclusion that often explain their involvement in these situations. And then let's take a look at this headline, which is from The Sun. I could have chosen any other, but look at this one. Mule Mom. Brit Mom arrested with son 6 over 1.6 million drug smuggling plot in Mauritius facing a year in hellhole jail before trial. Notice how the headline itself stigmatizes the woman by framing her identity primarily as a mother involved in a drug case, reinforcing moral judgment about her role as a parent rather than focusing on the facts of the case. This is a powerful example of how stigma operates through language and through social media. And it is very important to remember that these dynamics are not limited to Latin America. They occur worldwide, across different legal systems and media landscapes. As we have been discussing, people living with substance use disorders encounter many forms of stigma. They may experience self-stigma, blaming themselves, feeling hopeless, or believing that they are undeserving of help. Stigma can also come from within the recovery community itself, especially towards those who use medication as part of their treatment. And this is another very important point. Think about it. No one would shame a person with diabetes for needing insulin. Yet, people managing addiction with life-saving medications are often criticized and judged. For instance, some 12-step programs don't fully embrace medication-assisted treatment, MIT. There is a tendency to think they are still using an opioid, it's just a crutch, they are still addicted, they are not really in recovery, they are stuck, they are not moving forward, medication is just another form of social control, or also even calling medication as liquid handcuff. I think that I'm sure you have heard this expression before. So stigma can also come from health professionals, the very people meant to provide care. We have already seen examples in the medical system, persistent myths that treatment doesn't work or that people with addiction cannot recover, and this can lead to harmful practices. Patients on agonist therapy may be denied access to post-acute care facilities. They may be refused organ transplants, and people mandated to treatment as a condition of probation can even face imprisonment if their toxicology screens show use, despite being adherent to treatment. I have seen this so many times. Finally, there is the widespread stigma from society at large, the belief that substance use disorders is simply a choice rather than a health condition. So let's read over here. Stigma is complex. It's based on a relationship between an attribute and a stereotype that assigns undesirable labels to a person with that attribute. When we say that stigma is complex, we mean that it is not just about individual prejudice. It is created through a relationship between an attribute, for example, having a substance use disorder, and a stereotype. For example, the belief that people with addictions are irresponsible or are dangerous. That stereotype then assigns an undesirable label to the person, such as addict or criminal. This label reduces the person to one single characteristic and ignores the rest of their identity. In other words, stigma is not about who the person really is, but about how society interprets one attribute through a negative stereotype. So, stigma, of course, has more than one dimension, and groups with different cultural norms often face additional stigma. For example, race, nationality, ethnicity. People with lived experience who have a substance use disorder and co-occurring mental health or physical health diagnosis may experience additional stigma. And stigma also occurs at increased rates in various settings: justice system, substance use disorders, behavioral health, medical and social services. Now let's take a look at the effects of prejudice, discrimination, and stigma and how they impact social acceptance from friends or family. As we can see, prejudice and discrimination exclude people with mental health and substance use challenges from activities that are open to other people. The exclusion limits people's ability to get or keep employment, get or keep housing, get health care, including, of course, mental health and substance use disorder treatments, be accepted by family or friends, find, make friends, or have other long-term relationships, and take part in social activities. Prejudice and discrimination often become internalized by people with mental health or substance use challenges. This treatment leads them to believe the negative things, which is what we describe as self-stigma or internalized stigma, have lower self-esteem because of guilt or because of shame, avoid getting the help they need, and risk that mental health or substance use disorder issues are less likely to decrease or end. But something very important also is that stigma is not only inhibiting help seeking, but it may also weaken the impact of help when it is eventually accessed. And the last part of our slide shows us that stigma doesn't affect everyone in the same way. This is the concept of intersectionality that we will see. For marginalized groups, such as racial and ethnic minorities, migrants, or other excluded communities, stigma often translates into very, very concrete and unequal outcomes. Higher overdose and death rates, less access and poorer quality of treatments, a greater likelihood of incarceration instead of care, and a lack of research that could inform better responses for them. Okay, so let's move a little bit forward. I hope I'm making myself clear. I cannot see you, but then we can talk when the presentation finishes. So, the terminology used to describe substance use disorders has also contributed to stigma. This slide shows us the main consequences of stigma. First, it discredits a person or a group, making them socially devalued. Second, it marginalized them, leading to inequality and discrimination. And third, it limits their ability to achieve their full potential, preventing them from experiencing happiness and fulfillment. Of course, these harms are even greater for people who face multiple layers of stigma, for example, women, migrants, or indigenous people, where cultural prejudice, discrimination, and social exclusion overlap. Stigma, and this is something we have to bear in mind, stigma remains the biggest barrier to substance use disorder treatment faced by users, and the terminology used to describe substance use disorders has contributed to the stigma. So, if we want people to access treatment, we certainly need to address stigma. To better understand how language shapes our perceptions, I would like to share a very illustrative study that experimentally evaluated the impact of the words we use. In this study, the researchers wanted to test whether the words we use to describe people with substance-related conditions influence attitudes and decisions about their care. They created two versions of the same case study, changing only the terminology used to describe the person. In one version, the person was called substance abuser. In the other version, the person was described as a person with a substance use disorder. Notice the difference. The first experiment included general participants who read the cases and were asked to recommend what type of response they thought was appropriate. The case study was then replicated with clinicians, which were mental health professionals, at two different mental health conferences to test whether professional training would make any difference. So, the results. When the person was labeled as substance abuser, participants were significantly more likely to recommend punitive actions, punishment, sanctions, control. When described as a person with a substance use disorder, on the other hand, participants were more likely to recommend therapeutic actions, treatment, support, and this is very important. The results were the same among clinicians as they were in the general participants, and this showed that even trained professionals are influenced by the stigmatizing language. So why this matters? Because the study demonstrates that the language is not neutral. It shapes perceptions, it shapes decisions in very concrete ways. Using person-first language, I mean person with a substance use disorder, can help reduce stigma and promote treatment rather than punishment. This is really important and is interesting for us. This evidence highlights the need to change not only policies, but also everyday language in clinical practice, in media, and in communities. So now let's check another study with very similar findings. In this case, research shows also that words really matter, not only in how we view people, but also in how willing we are to support them. The study asked different groups, general members of the public, recovery communities, and professionals working in mental health and addiction services about their reactions to commonly used phrases in the recovery field. The goal in this case was to measure whether certain words or phrases generated positive, neutral, or negative attitudes toward people with substance use disorders and toward treatment policies. The results, again, show that the term addict consistently triggered negative attitudes about the person it described. But when more positive person-first language was used, such as person with a substance use disorder, public support increased for effective policies, more funding for services, see this, and more compassionate engagement with those affected. This demonstrates again and again that language has real consequences, both at the individual and the society level. Don Coihis, founder of White Vision and the World Variety Movement, which is a non-profit dedicated to culturally grounded healing for indigenous communities, reminds us of the power of words. He says, and I guess some of you already read this and know this phrase, which is beautiful. Words are important. If you want to care for something, you call it a flower. If you want to kill something, you call it a weed. And I think it is really important that we can stop and think a little bit about this metaphor, because it captures exactly what happens with stigma. The language we choose can nurture dignity and compassion, or it can justify rejection, punishment, and exclusion. Words are never neutral. They shape how we see people and how we decide whether to support them or to turn away from them. Now, to bring these ideas down to practice, there are a few guiding principles we can keep in mind. Be mindful. Stigma and discrimination often begin long before people ever seek recovery support services. Engagement. It is important to use dignified language across all contexts, whether in people who use drug health, prevention, public and behavioral health, or harm reduction settings. Then, good service in intentionality. Remember that many people carry them life stories where substance use disorder is deeply interwoven with cultural significant stigma and trauma. And then it is very important that we seek to understand the person as a whole. This means looking beyond the diagnosis, taking into account their history, their exposure to trauma, the presence of co-occurring conditions in mental health, physical health, and also substance use disorder. We need to have a comprehensive view of the person. And these are the evidence-based interventions to end stigma. Use contact. Of course, first of all, we can use contact. This means bringing recovering messages in our conversations and communities. It also means modeling recovery to peers, families, stakeholders, and the broader community, showing by example that recovery is something real and possible. And it is about holding each other accountable, using teachable moments when stigma shows up at that exact moment to correct and educate, but of course in a very constructive way. So in the second step, we use language. We need to use language wisely. That means modeling non-stigmatizing and recovery-oriented language every day. And even performing what we call a language audit, which I will tell you, there are very simple ways to carry on a language audit, examining the words we use in organizations, we use in the media, in the services, to ensure that they reflect respect and dignity. And third, we use education, sharing the science of addiction and recovery, which helps to dismantle the myths and the prejudice. It is equally important that we highlight that our stories have power. The lived experience of people in recovery can change minds, reduce stigma, and, of course, inspire hope. So, how do we actually change perceptions? One way is by thinking of ourselves as role models and setting the example, right? When we talk about changing perceptions, the first step is to look inward. We need to assess our own attitudes, beliefs, our own practices, because the way we see others is often shaped by what we carry inside. From there, it is essential to stay focused on non-stigmatizing language. This means choosing words that are medically descriptive and accurate, and not choosing words that might be moralistic or judgmental. Remember once more that the language we use does not just describe reality, but it helps very much to shape it. We must also commit to educating ourselves and, just as importantly, to being educators for others. Each of us, wherever we are, wherever we are working, can become a voice that challenges stereotypes and opens new perspectives. Part of this work is learning to embrace all pathways to recovery, and this is also very important, that we recognize that there are a lot of ways in which people can recover. There is no single solution, and every people's journey is unique and needs to be respected. And finally, the true change requires courage, and this is really important too, because it requires courage to challenge institutions and practice which are established and which are responsible of perpetuating stigma and exclusion. So by modeling our actions in our daily work and interactions, we can become role models for how to transform perceptions at every level. One practical tool that organizations can use is a language audit. This means systematically reviewing the words we use in our documents, training materials, websites, and even in our daily communication, especially if we are running a clinic or a health institution. There are many ways in which communicate. It can be WhatsApp messages, emails, also the way in which we talk with our users or patients. The idea is to identify language that may be stigmatizing and replace it with alternatives that are person-centered and recovery-oriented. A simple way, very, very simple way, and now that we have artificial intelligence, we will have more, this might become even simpler, but you can use the search and replace function in electronic documents. We have done this in our mental health center, and it worked really, really good, and we discovered how many stigmatizing language we were using without even being conscious of that. So instead of using addict, you can replace it with person with a substance use disorder. Instead of saying abuse, you can replace it with use or misuse. These small but intentional changes can significantly improve the quality of care and reduce stigma in the way we communicate. Then I have another resource that I want to share with you. Remember that Hannah said that the presentation is going to be sent to you by email, so then you can have all this material. But a really helpful resource is the document Words Matter, How Language Choice Can Reduce Stigma, which was developed by SAMHSA's Center for the Application of Prevention Technologies in November 2017. Unfortunately, I think this one is not in Spanish, but it could be a really good activity to translate it. And also, talking about artificial intelligence, now it's really very, very easy to translate a document because this one is really good. It provides concrete examples of harmful terms and suggests respectful, accurate alternatives. It is a short document, but very, very powerful. So it is not only about individual word choices, but also about changing the overall narrative. The overall narrative we use around substance use and recovery, the idea of recovery. Organizations can integrate this research into staff training, which is something that we must do. Policy writing and public communication, ensuring that language consistently reflects dignity and respect for people with lived experience. The guide is, of course, freely available online, and I can send it to you by mail also. But it is really a very good material to train the staff. And when we talk about training the staff, we are not talking only about mental health care professionals, but also administrative people and everyone who is interchanging and in contact with the users and the patients. If you are not familiar with William White and you are interested in learning more about recovery advocacy, recovery messaging, and recovery material in general, you should check out his work, which is currently now in Chestnut Health System webpage. It is called William White Library or Papers. Look at his phrase. Words have immense power to wound or heal. The right words catalyze personal transformation and offer invitations to citizenship and community service. The wrong words stigmatize and disempower. William White is one of the most influential figures in the field of recovery, not only because of his contributions on language. That's why I'm telling you, please go. If you don't know him, read his papers. There are a lot of very new investigations that he has done and directed, but also because he invites us to view recovery as a historical and community-based movement. Conceptually speaking, this is very, very great. He shows how life stories, social networks, and a sense of belonging are just as important as clinical treatments. And he also emphasizes the need to value all recovery pathways and not reduce them to a single model. And this is very important. We are going to see the concept in the next slide. But White is trying to make us think and broadens our understanding of what it means to support someone going through a recovery process. So let's take a look at this activity. You see here a simple reflection tool with 4 squares. The idea is take a piece of paper, here you have it, right? Divide it into 4. I don't know if you have done this before, but you can do it with your staff. You can do it with the users. You can do it with recovery staff also. No? But the idea is to reflect about this in a very simple way. So take a piece of paper, divide it into 4, and draw what recovery means to you in each square. Then we reflect. Now, is this something relevant and practical right now? Is this a great idea to implement now? Then we think about the how. Is this something powerful that needs a bit of unpacking? Is this something powerful that deserves to be amplified? And the wow is the brilliant, when you have a brilliant and very good idea that needs to be heard by others and that you will share with the rest of the people, either in the therapeutical group, either in the rest of the staff. Okay? This activity reminds us that recovery and equity are non-static concepts. They depend on how we see them, how we talk about them, and how we share them with others. And that brings us to the image on the side, the difference between equality and equity. Look at this image you have over here, because the idea is to discuss the intersection of equity and consider how knowing it can change your narrative, service, perceptions, and interactions with others. This is something that we need to share and discuss inside the groups we work with. Intersectionality is a concept that I use a lot. The National Institute of Health reminds us that stigma does not exist in isolation. It intersects with racism, sexism, ageism, ableism, or the stigma of incarceration and poverty. That means that a person with a substance use disorder who is also a woman, or a person of color, or someone with a disability often faces multiple overlapping barriers. So when we design services or when we choose our words, we need to ask ourselves, are we giving everyone the same vibe? Or are we making sure people actually get what they need to move forward? Are we using language that empowers, or are we using language that reinforces stigma? Are we ready to embrace equity as a guiding principle in our advocacy and in our practice? If we can take these questions with us, the now, the how, and the wow, then we will be better prepared to build systems of care that are not only effective, but also fair and equitable. And now at this moment, and with this case, I think I might be finishing. So it's quite early. I'm glad, because we will have time for comments and sharing stories if you want to share with me. Let me share a story that reflects the complexity of what we have been discussing. I will talk about Juana. Of course, this is not her real name. Juana is a 36-year-old woman from a rural town in Bolivia. She migrated to Argentina seeking better opportunities, but living extreme poverty. She was living in a really poor neighborhood in the center of the city. She spoke mostly Quechua, which is an idiom spoken in Bolivia, and not Spanish at all. And she had really little access to rights or information. She even couldn't read or write. She didn't know how to write or read. One day, after being found intoxicated, she had 6 daughters. They were removed from her care and placed in different state homes, separated from each other, without explanation in a language Juana could understand. I mean, this is not constitutional, separating sisters in different state homes. Yes, but as these homes are really overcrowded, they didn't have space for the sisters to be together. So each one was separated in a very different institution. Juana didn't understand anything. For months, she was unable to see them because she was receiving letters which she couldn't read. Her husband could barely read, but didn't understand the technical languages in which the letters were written. And also, she did not have legal representation. She did not understand the procedures. And she was really, really distressed. And you know what happened when you are more distressed. uh, and you were already drinking, right? Um, you start to drink more. So things get worse and worse. Um, when Juana entered the treatment, uh, at that moment, I'm talking a long time ago, the first time she entered a treatment in her life, instead of receiving support, she was judged and discriminated against for her nationality, her poverty, and her substance use. She was discriminated by her own peers and also by the professionals who were attending her. They didn't want to see her because she was not clean, because she smelled, because sometimes she went to the therapy group having been drunk. And at that moment, at that point of the story, she believed that she had no rights at all, especially because she was a migrant and she didn't know her legal status. I first met Juana when she arrived at the institution I coordinated. I tried to be her companion, and I really witnessed, and I was the witness through her recovery journey. This makes me feel really emotional because, with the help of a lawyer, that's the nonprofit organization I worked for, we could find really quickly. An interpreter, of course, because Juana started understanding a little bit more of Spanish, but it was really difficult to tell her what was going on and what she needed to do to recover her daughters. So what we could do was find an interpreter. You know how we make contact with IOM, which is the United Nations Organization for Migrations, and they found us an interpreter for free. And then we had the whole team willing to listen to her story. And Juana began to understand her legal situation and to realize that she did have rights. So, step by step, first she reduced her drinking, then she started to regain daily routines, and of course, she grew stronger in her determination to reunite with her daughters. Her recovery was not linear, of course. There were good moments, there were bad moments, there were moments in which she uh, thought she was not going to be strong enough. There were moments in which she would disappear for a week or two and we couldn't find her. We tried to send the social worker uh, who knew the neighborhood in which she lives, to find her, and she was nowhere. But what made the difference was not punishment or abstinence at all costs. On the contrary, clear information, cultural sensitivity, and really genuine support. When we talk about cultural sensitivity, we start by understanding that she was not able to understand our own language. She could understand the nonverbal language, and she would understand perfectly well that she was being discriminated wherever she went. So this story shows how stigma and gender-based violence and poverty and migration and lack of access to justice commonly intersect. And I think it reminds us that problematic substance use cannot be seen in isolation, but must be understood within broader context of inequality and exclusion. Of course, Juana's story finished in the best way, and I always say it's thanks to her own strength. She only needed a little bit of respect and support, and she has reunited with her 6 daughters again, and she is still coming to treatment. She's now in an ambulatory treatment, coming twice a week, and everything is going well. So recovery does not begin with abstinence necessarily. It begins when a person is truly seen, it's truly heard, and supported as a human being with rights. Well, now thank you very much for your time and for staying with me in this webinar. We are just finishing the presentation, and now we have a space for any comments, any questions, or thoughts or stories you want to share with us. I hope you have liked what we prepared for you today. I am really happy, and I'm truly emotional when I talk about these topics. So I hope you are moved too, because the changes become when we are moved to do things better. Okay, so thank you very much. I will finish presenting so I can see you. So Hannah, I might need your help here.
Yeah, hello Carolina. So it looks like it'll just be you and I on the call. Hannah is having some technical difficulties.
Okay.
So going to then go ahead and then share a few accesses with you so we can see the questions and then we can go through and see how best we can answer them. So yes. So now if you look at the top right corner again, you should see one that says questions right after the comments, and we'll see a lot of questions coming through. It's quite a lot, so we can filter through from the bottom and then answer the attendees. Please let me know if you can see that.
I should see the questions. Let me see
So
if I
if you
can
look at
see
the
them.
right, yes, so we have a lot of questions coming in. So if we could treat them in order of how they came in, we'd see right from the bottom we have a few coming in earlier during your presentations before the current one. So maybe we can take a look at them. There's one from Alda that says, "How does a person deal with drug this? How does a person who deals with drug disorder face stigmas?" I think that in the rest of your presentation you did cover that a little bit. So a few of them are comments. Okay, so here's another one from Graham, and he's asking, why is the word alcoholic used universally and not words like behavioral problem? Is that
Well, this is something I have. I will share with you. Remember, I told you this document. Alcoholic is not a word that is respectful to be used. I mean, it's a word that is stigmatizing. You can say, of course, a person with behavioral problems, but it's better if you say a person having a substance use disorder um, as a generic way, not specifying in any case the substance in which the person is having a problem. But saying alcoholic is like saying addict. It's stigmatizing, and it's one of the words we should need to change. Um, While some substance use might be illegal or unhealthy, we should limit language about substance use disorders exclusive to situations where a clinical diagnosis has been made. But it is really important to put the person in the center of our speech. So that's why we should not be using alcoholic anymore.
right? That's very formative. And if you can still can you see the section where the questions are all coming in? There are a
Yes, I see.
few
Yes.
bunch
Um,
questions.
I see. There is so much inconsistency with the use of the term alcoholic. The AA use Alcoholics Anonymous. Yes, I know that is something. Well, but that is uh, like a like a branch name, you know. It is something that, and they define themselves as alcoholics, and the 12 steps also define people define themselves as addicts. That is something we work a lot when we go to those groups to speak about language, and the importance of not being identified with only the substance use you are trying to leave behind. But it is a way of working that it is very important to address, but it is not something we can do rashly or directly, because they present themselves like this. Hello, my name is Carolina Borlero. I'm an addict, and they build their identity uh, there. But it's a program that works very much, and in that case, I think it is very complex to think ways in which they can change their language. We have been talking here in Argentina with a lot of those organizations, and they're starting to think if there is a better way to work about that. Um, and sometimes they say, well, they will start by defining themselves like this, and then they will try to soften their words. They will try to change the words. They will try to not only define their identity on calling themselves alcoholics or addicts. Yes, but it is really complex. So thank you very much for pointing that out. Hi, Gloria. Gloria Salinas is here. Thank you very much for listening. Um, Let me see, Christine. How can one help a person who is going through self-stigmatization because some people stigmatize themselves? This is a very accurate question. I love it very much. Thank you for bringing this. I think it is very important to address self-stigma. Self-stigma can be very damaging. I have just said that because it internalizes all the negative messages society sends. One of the best ways to help is to create a safe space where a person feels valued and respected. Encourage them to see recovery as a strength, not a weakness, and highlight their progress and capabilities. Peer support is working very good for that also. And connecting with others who have gone through similar experience is also very powerful to counter self-stigma. And of course, if you have the opportunity to have an individual space of therapy, that could be very, very good too. I'm still reading the questions. Some cultures, yes.
Hi
Back.
there. I'm back.
Hi,
Guys.
hi, Dana. Okay, thank
Yeah.
you.
Tech difficulties there. I apologize for
Don't
those.
worry.
Technology, right? It throws a wrench in things sometimes. Um, I do know that you've answered a couple of these questions, so I apologize if I ask ones that you have answered already. Please just let me know. Um, I did see one that I wanted to touch upon, and maybe you've already asked it or answered it, but um, it highlights that many organizations like Narcotics Anonymous, Anonymous still use that stigmatizing language. And someone just asked kind of what your thoughts are on that those organizations and support groups that, undoubtedly look at addiction as being a disease and not a moral failing, so on and so forth, but yet still use that language. Are you able to share some of your thoughts on that?
Yes, yes, thank you. And I have shared a couple of thoughts about that, and I point out that it is a very good question and difficult to address. Um, Maybe I can give another insight on that one because I see that it is a repeated question, right? Let me see. I have a lot of experience working with these organizations. Um, and I respect them very, very, very much because they are everywhere. They get near people in places that nobody will be other than them. They still use terms that can feel stigmatizing because they, of course, come from older traditions. Um, but I want to point out that it is important to recognize that these communities have helped really millions of people in recovery. Uh, so our key is to honor their role uh, while also encourage them to use a more inclusive person-first language. That is what we do in the non-profit organization I work at. We try to um, work together with mutual aid groups like AA and NA, giving these recommendations, giving this information, because we have a lot of studies like the ones I show you today, giving this evidence-based information. So we try to um, think about how language evolves, so we can all contribute together to gain that shift without dismissing the support that these groups provide. I think that that is the key.
Yes, wonderful answer and very well said. And yes, like you said, language is constantly evolving. A lot of great questions coming in. I want to thank everyone for submitting such great questions. We may not be able to get to all of them in the time that we have left. We'll try to get through as many as we can. Christine asks, how can one help someone who is going through self-stigmatization? Because some people do stigmatize themselves. Yes, this was a part of your presentation that I was also really interested in. If you could share a little bit more about self-stigmatization and how we can help.
Yes, I think I have addressed that one, but um, I think there are a lot of ways, right? We have been talking about how this impacts their inner self-esteem and how self-esteem can be very painful because people internalize the negative messages they have heard from society. Um, One way we can help is by actively challenging those negative beliefs. I mean, of course, in the group therapy space, but mostly when we have the opportunity to have an individual space of therapy. We can challenge those negative beliefs. We can start by asking where those ideas came from. And they will be associating that these beliefs were not uh, during the whole life in their heads or in their hearts. And we should remind the person that substance use disorder is a health condition once and again, and not a moral failure. We can also offer empathy. Empathy, we always say this is the cure for stigma and for self-stigma too. It is our duty to highlight their strengths and to connect them with supportive communities and groups where they will feel valued and accepted. Um, Research, as I have just shown, shows that social support and person-first language play a big role in reducing self-stigma. So when we have our spaces working with this person-first language, working with empathy, self-stigma is also going to be addressed, and people will feel again valued and respected.
Thank you for sharing. That's really powerful. I see that someone else asks, around slide 10, you stated that stigma was the strongest factor keeping people from seeking help. Can you share a little bit more about why you say that, and if you have any research that shows that's valid? This person says that they hear this a lot, but as a researcher, they have a difficult time providing quote unquote proof for that concept.
Well, I can give you a lot of information about that. I don't know if I shared my email. I think so, but if not, I will share it with you. I don't know if I can write in the chat, but I will double check in a minute. There are a lot of information and researches about that. Especially we have one here in Argentina from 2019, where we carried out a research in different hospitals and mental health centers from different parts of the country. Argentina is a very, very huge country, and we have different provinces and different social realities. And what we did in that moment was to conduct structured interviews to mental health professionals and ask them what they thought about people having substance use disorders. And the response we had was really not surprising for us, but you still get some shock when you when you find in reality what you know and what you feel, right? And we had different categories of information where they felt pity, where they felt rejection, where they felt that people having substance use disorders were like, let me check this word in English, were like not having all their cognition at their disposition, and a lot of prejudices about them. And we also found that that affected their way in which they attend or even they give a shift for those persons to seek for care. We also find that substance use disorder services are most of the times really difficult to access. If you get inside a hospital here in Argentina, you will see that the substance use disorder treatments are at the back of the hospital in a really dark space. Not You won't be able to find it easily. And the times in which the help is provided is the time in which nobody will go because it's very early in the morning. Um, and so we concluded that all these prejudices were really barriers for people to get help. That is one research we did here in our country, and it was really uh, powerful to find. But I can give you a lot of information about that because I'm always seeking for new researches, and there are a lot you can use to justify that information. So count on me on sending you the material.
Wonderful. Thank you so much. I think anytime that we can share research and resources like that, that shows, that what we're talking about is valid and tested is just wonderful. So it's great to hear that you have, examples of what that research looks like and that you'll be able to share them. Um, Again, I apologize if this is a question that you've already answered, let me know. But another kind of research-based question. And Joseph says, some cultures seem to stigmatize more than others. Is there a study done or research out there to show how different cultures can affect people seeking help? Oh, you are on mute.
Sorry. Can you hear me now?
Yes, we can.
Okay. Um, well, that's a very, very good question. I don't know if there are studies that might show which cultures stigmatize more, but there are a lot of publications on cultures stigmatizing substance use disorder people. I mean, there are countries in which substance use disorders are uh, considered as something that people might die for if they say they're having these problems, Um, and of course, that level of stigmatization is really like a living or death problem. So imagine in that point, it is a really we could be real blind if we don't say that in those countries the level of stigmatization is even harder. But research showing that stigma is shaped by culture is really big. For example, the WHO's World Drug Reports and studies published in journals like The Lancet, Psychiatry, or in Addiction magazine show all the time that in some cultures substance use is framed more as a moral or criminal issue, and this increases stigma. In others, it is recognized as a health condition in some countries specifically, and this reduces, of course, stigma. But cultural and religious norms, gender roles, and the strength of community networks um, all influence how much stigma people face. I don't know if, of course, you have information in all these researches I'm telling you about. Also, in the World Drug Report, you have information from different cultures and how the different continents, not specifically countries, but maybe continents, have a view on addictions. But I don't know if there is like a global study. I think when we have ISSUP meetings or this kind of webinars, I always think it would be a really good opportunity to do like a massive research uh, because it would be really, really interesting and powerful to determine something like that. So thank you very much for that question. And I will keep on thinking if there is one research uh, addressing this perspective you're bringing.
Thank you. That's a great answer. And I think that, yeah, if anything, these webinars and when you get together and network with folks, that it shows you how much research there is that can be done out there, and all of the different ideas and things that we still need to look into and investigate. There are a couple of questions that are kind of along the same thread and in the same vein, so I'm going to kind of try to combine some of them. But some folks have highlighted that they work with different groups of folks that do show lots of stigma, and they don't exactly know how to navigate, helping those folks no longer use stigmatizing language and become more open-minded. So I think the question is just how can individuals really help reduce the prevalence of negative language surrounding substance use disorder, and how can we start those conversations with the people and groups that we work with?
That's a great question, because that is a real challenge that I try to like address in this presentation. I think that becoming more open-minded starts with awareness, um, and recognizing our own biases, recognizing our own biases while talking with others. Even us that we are like specialists in interculturality, I always say that I also need to recognize my own biases. Um, then listening to lived experiences is really powerful. Hearing directly from people in different groups helps challenge stereotypes. Um, we have done that a lot inside the neighborhoods, inside the club, inside the churches, people telling their stories and talking about how we build stereotypes and how stereotypes are like the seed of discrimination acts. And giving workshops on that is really powerful. I mean, education is also the key, because research shows that contact-based approaches, when people meet and work alongside those that are stigmatized, this reduces prejudice significantly. And also always using respectful person first language and telling them what you see and how. That's why I spoke about Juana, because I think that when you tell those kind of stories, it becomes, I don't know if obvious is the word, but it becomes visible for the person that language has that kind of impact in a life, and that you can really open your mind and try at least to put your thoughts into parentheses. So, I mean, openness grows from three things. awareness of our own biases, listening to people's lived experiences, and using respectful person first language. And never diminishes the power of stories. Uh, if people with lived experience can tell their own stories, that is really, really powerful too.
Great answer. Yes, I think I have personally seen in my both personal life and professional life the effect that telling stories and sharing openly and boldly can have in changing minds and changing opinions. So we are sadly at the end of our time together here. I want to say a huge thank you to Carolina again for helping us to continue this series with this amazing presentation and really amazing Q&A session. I know I personally learned a lot and have more examples and more ideas to take back to the work that I do here every day. And I'm sure that the attendees feel the same. I see that the questions box has a lot of thank yous, great presentation, so on and so forth. I also want to say thank you to all of you for being here today, for taking time out of your day to be here and to join us for this great hour and a half together. As we've heard today, recovery is not a one size fits all journey, and stigma can greatly impact someone's recovery journey. It is shaped by personal experience, cultural access, and community support. And I think as we continue this journey together, we invite you to reflect on the information you heard here today and how your work can honor and uplift those affected by substance use disorder. As we mentioned at the beginning, you will receive a follow-up email shortly with the webinar recording, slides, and additional resources. Please also take a moment to complete the brief feedback survey. We'd love to know your thoughts on how we can improve this webinar. We will also see you again here in 2 weeks at the same time when we continue our returning to basics phase with the power of storytelling. Until then, thank you all so much again for being here. Thank you to Carolina. Thank you to ISSUP. And we hope you all take care until we see you next time. Thank you. Bye-bye.